This is a 64-year-old hypertensive lady with body surface area is 1.63, blood pressure is 135/80. She's in combined therapy, and heart rate is 74 beats per second. So let's have a look at her exam. Here we have a four-chamber view, an apical four-chamber view. Now it looks quite good. You see the endocardium on the apical segment approaches itself quite nicely, closes the apex, and we can see the endocardium, both the septum and lateral wall. Seems like a good function. And then let's go here. So the long axis in this four-chamber view is 6.5 centimeters. Now, this was done in the end expiration as recommended by guidelines. This other four-chamber was taken at end inspiration, so with lungs full, which shifted the heart, and you can see that the long axis here appears to be longer. Okay, so let's see the long axis. Here it is, 7.4 centimeters. Okay, that's much better than 6.5. So this is better, and this one is clearly foreshortened. So again, in the not foreshortened view, we have made the planimetry. You see that we stayed on the endocardium all along the lateral wall and inferior septum, starting from the junction, the base of the leaflets here on the mitral annulus. And by the Simpson rule, the software builds up these cylinders here, stacks them up, calculates the volume of each one, and then adds up the volume to obtain, you see, a 56.6 end diastolic milliliters volume. And when you just saw that the long axis was 7.4. This is the image without the endocardium, with and without. We shift from planimetry with and without to be sure that we have done a good job on the endocardium. Then we move to the end systolic frame. You see the mitral valve is closed. You still see the endocardium here. This is where we did the planimetry. So now we have, compared to the end diastolic volume, we have a bit more than 23 milliliters, and this gives us an ejection fraction monoplane four-chamber view of 58.9%. Again, with the planimetry and without the planimetry. So you can see that we performed the planimetry just where the endocardium should be. And then we move on to the apical two-chamber view. Here you can see well the endocardium, and this is the planimetry. Okay, so indeed we have 78 milliliters of end diastolic volume and almost 24 of end systolic volume. So in the end, the software gives us the biplane volume, which is 67 milliliters. The end systolic biplane volume, which is almost 24, and the biplane ejection fraction, which is 65%. Remember the long axis length in the four-chamber view was 7.4. Look at the long axis end diastolic length in the two-chamber view, it's 7.6. So we did a good job because there's less than 2 millimeters difference between the two axes, which means thus that the four-chamber view was not foreshortened, and we did a good job by choosing the right views for our biplane ejection fraction and volumes. And this is what we're going to talk about today, performing a biplane, volumes and ejection fraction, and also a look at how to measure mass and left ventricular geometry. Hello and welcome to the Echo by Web YouTube channel. It is a channel for professionals, cardiologists and sonographers, but not only, dedicated to the world of echocardiography. The aim of this channel is to provide the basic physiopathology and methodology which are necessary to understand how to perform and interpret a complete echocardiographic examination today. This channel will deal with many of the topics we all have to engage with in daily practice: valvulopathies, cardiomyopathies, systolic and diastolic function, and also new technologies like left ventricular systolic strain analysis of the left ventricle. My name is Paolo Barbier. I am broadcasting from Italy. I am a cardiologist with a special interest in echocardiography, and I will guide you through talks and clinical cases from my clinical experience, addressing a wide range of echocardiography topics. My imaging, the image that you will see in my channel, are based on patients studied in Italy and in Northeast China, where I have worked for about 5 years. Echo by Web is also a website, echobyweb.com, where you will find much of the materials I will present you in this channel. So let's have a look. This is the homepage. Up here in About, you will find my credentials. And then we have Atlas, 2 atlases, which is work in progress by now. Transthoracic and transesophageal, here are different chapters. In Ecolab, you will find normal values for echocardiography, scores like the Wilkins scores, analysis and quantification of the left ventricle, the mitral valve, the Montgomery plaque classification, for example. And then you will find formulas and calculations, guidelines, references, a complete echocardiographic, an example of a complete echocardiographic examination. And online calculators. Here I have created Excel spreadsheets that you can use on the website with calculations for echocardiography, evaluation of diastolic function, and based on the 2016 guidelines, and based on the European guidelines, indications for surgery or transcatheter therapy for the different valves, aortic, mitral, and tricuspid. For example, the calculator here for diastolic function, if you scroll down, is here. Okay, so in this window, which you can use if you fill up the yellow fields, like for example, ejection fraction, the 2D echocardiographic examination, various measurements like mitral valve, tissue Doppler, etc. The Excel spreadsheet will give you, based on the variables that you input as output, the filling pressures, estimated filling pressures, and diastolic function class. In here, you can see the QR code to access the Echo by Web site, for example, for your cell phone right away. The topic of this talk, which spans over 2 videos, is the echocardiographic analysis of left ventricular volumes and mass as seen in the real world. It is a basic approach to this topic. Now, these talks, this and the others, assume that you have a basic understanding on how to perform a basic echocardiographic examination and measurements and calculations. However, you will find in my website echobyweb.com that I have just mentioned a large quantity of material, educational materials to address this point and help you in calculations and measurements. In this talk, we are going to review how to measure left ventricular mass index and the relative wall thickness index by looking at MO measurements, 2D and 3D measurements. Then we will move on to how to measure left ventricular volumes, and we will see the very important issue of the left ventricular geometry and how to respect it. And then we will see pitfalls that occur when LV geometry is incorrect. And at the end, a quick look at the 3D exam concerning volumes and ejection fraction. And this is video number 1 from the introduction to 3D measurements of LV mass. The central focus of our echocardiographic examination is the quantification of the size and function of the cardiac chambers and necessarily of the left ventricular chamber, of which we will talk today. Your essential references in the literature are the following. Up here on the left, the 2017 European Association of Cardiovascular Imaging document on the standardization of echocardiographic reporting, which follows the 2015 Associated American and European recommendation for the quantification of the cardiac chambers. The table here on the right from the European document concerning the standardization of echocardiographic reporting lists the required measurements of indexed volume, biplane and diastolic and systolic index volume, and then the mass index and the relative wall thickness index and the biplane ejection fraction. And here on the right you see the cutoff values separated by sex. The left ventricular mass is a very important parameter to measure because it is an important risk factor and is a strong predictor of cardiovascular events. But there is also another related and necessary measure mentioned in the guidelines, in the European document about the report, that is the relative wall thickness. So the ratio between the thickness of the wall H and the radius of the left ventricular chamber. The table on the left here shows, in the table you see the normal values. This table comes from the 2015 document, American European document. The relative wall thickness index, we will see in a minute, is done with linear methods on the 2D imaging, and you see here the values, normal values are below 0.42, both sex. And with the 2D method, you measure mass, you divide by body surface area and you get the mass index, and these are the values partitioned by sex, 44 to 88 in women and 50 to 102 in men. Let's see the usefulness of the HR, the relative wall thickness index. On these Cartesian graph here, we have the left ventricular mass index on the x-axis, the horizontal axis, and on the vertical y-axis we have the relative wall thickness index. These are the cutoff values, 0.42, and these are the cutoff values for the mass index. And if we consider the cutoff in the cutoff values, we have 4 quadrants in this Cartesian graph. These 4 sectors identify 4 geometries for the left ventricle. We have normal geometry down here, in which the patient has a normal relative wall thickness and normal left ventricular mass index. And then up here on the upper left, we have concentric remodeling, and concentric remodeling is characterized by an increased relative wall thickness when mass index is still normal. Then we have eccentric hypertrophy, when there is a increase in left ventricular mass index with normal relative wall thickness. And then when both parameters are increased, we have concentric hypertrophy. So in eccentric hypertrophy, there is the increase in mass is mostly due to a predominant increase in LV volume. While in concentric hypertrophy, the increase in mass is secondary to both an increase in volume and an increase in the thickness. Whereas in concentric remodeling, we have a relative increase in the wall thickness with a normal, substantially a normal volume. In the context of arterial hypertension, it was observed that half of the patients, 50%, had normal geometry, whereas the prevalent hypertrophy model was eccentric hypertrophy. This is in hypertension, but there was also 13% of concentric remodeling in these patients. It is also noteworthy to note that the cardiovascular risk increases going from normal geometry to concentric remodeling. So concentric remodeling, it has been seen that there is a small but definitely increase in cardiovascular risk, which increases going to eccentric hypertrophy, and the risk is maximum with concentric hypertrophy. Now, in the field of cardiomyopathies, it has been seen recently that the restrictive phenotype cardiomyopathies can have either a normal geometry or a concentric remodeling geometry, whereas dilated cardiomyopathy typically has an eccentric hypertrophy phenotype, and hypertrophic cardiomyopathy and amyloidosis typically have a concentric hypertrophy phenotype. Let's start with the calculation of left ventricular mass. The calculation of the relative wall thickness index uses basically the same measurements. The mass, left ventricular mass, is determined by two factors: the thickness of the walls and the cavity volume. There are essentially three methods to calculate it today: the 2D linear, 2D formulas, and 3D direct. With the 2D linear methods, the measurements are made in the parasternal long axis view using 2D measurements. The M-mode exam should not be used anymore today because of the many pitfalls that we will see in a minute. Then we have the 2D formulas, truncated ellipsoid and area length in parasternal short axis and apical four-chamber projections. But these measurements have never substantially been used in clinical practice. And then we have the 3D direct in the apical projection and requires a 3D transducer. In the table here, you see the advantages and disadvantages of the three methods. The 2D linear is fast, is widely validated, it's been validated especially when used with the M mode. It is accurate if left ventricular geometry is normal. It is simple for population screening and it has been used extensively for this purpose. And the accuracy has improved in time with harmonic imaging. It is based, however, on the assumption that the left ventricle is a rotated ellipsoid with a long to short axis ratio of 2:1 mostly, and that there is a symmetric left ventricular hypertrophy distribution. So if it is inaccurate if the hypertrophy is asymmetrical. It greatly amplifies errors because the measurements are cubed, the measurement of the thickness and the cavity, and it tends to overestimate mass. The 2D formulas is, as I told you, not used, never been used because it's accurate, but it's quite complicated to do, and it needs a very good quality imaging. The 3D direct method is the best. There are no geometric assumptions needed because we use a 3D data set. It is more accurate. It has been demonstrated to be more accurate than the 2D methods and has a very high intra and interoperator reproducibilities. But you need, of course, very good imaging. You need a 3D probe, which in the community setting is not very widely used. It needs patient cooperation, and normal values are a little bit less established than with the 2D linear. There are not many screening data in this case. Now let's look at some examples. This is a very old image, a vintage image of the M-mode measurements of the left ventricle, and you can tell it's old. You can see up here of a simultaneous phonocardiogram. The measurements are performed at end diastole, and you determine end diastole with the Q wave of the EKG, the red circle here. That's a Q wave. And the measurements include the measurement of the cavity of the left ventricle and of the thickness of the septum, the anterior septum, and the posterior wall. Now for mass measurements, you only need the end diastolic measurements. But since we are looking at this M mode, let's also see the measurements performed in end systole, the diameter of which is used then for calculating the systolic function with M mode, which should not be used anymore, but it has a historical interest. End systole can be shown, identified on the M mode tracing by the maximum anterior displacement of the posterior wall here in B, this point, or by the, as in A, end systolic interventricular septum dip, which is this one, shown by the yellow arrow. The end systolic diameter is still important today, not much for the calculation of systolic function, fractional shortening, which, as I said, should not be used anymore. We should use the biplane volumes and ejection fraction. But it's still important. For example, in the guidelines, it has a role in the evaluation of aortic regurgitation and matter regurgitation. Now, it's easy to understand the maximum anterior movement of the posterior wall to identify the end systolic point. And what is exactly, as I said, the end systolic interventricular septal dip? It is this divide between the maximum posterior shift and thickening of the interventricular septum here, and this early diastolic posterior movement of the interventricular septum during early diastole, during the early filling of the right ventricle, which starts, tricuspid valve opens before the mitral valve, so the filling of the ventricle starts the right ventricle starts before the left ventricle, and so the septum is shifted here posteriorly towards left ventricular cavity. And so this movement is separated from the thickening, systolic thickening of the septum, and we always have this little dip here that identifies precisely end systole. Now let's look at the calculations for the calculation for left ventricular mass. Two formulas were introduced in the 80s for measuring left ventricular mass. The American Society of Echocardiography, ASC formula, by Devereux in 1986, shown here in yellow with the leading edge to leading edge method, and the Penn convention formula, also by Devereux, but corrected so to include the thickness of both the septal and posterior wall endocardium in the measurement of the LV diameter, and shown here in blue. Also, in this Penn convention formula, the thickness of both the septum and posterior wall exclude the thickness of the right ventricular endocardium from the septum and of the pericardium from the posterior wall. Now, to understand the measurements, we must understand the concept of leading edge and of trailing edge in M-mode echocardiography. With this technique, the M-mode, any tissue interface, as shown here, has a certain discrete width, shown here by the thicker and thinner line. So each interface here, thicker and thinner line. The first line towards the transducer up here on the chest wall is the leading edge, and the posterior line is the second line, is the trailing edge. So the width of the interface is included or excluded from the measurement, depending if we measure from a leading edge or from the trailing edge. So the endocardium here, the right ventricular endocardium, this is right ventricular cavity, this is the septum, is included in the measurement of the septum here with the ASC standard, and is excluded with the Penn convention here in the measurement of the septum. So with the Penn convention, the diameter here is bigger than with the ASC standard because it includes both the endocardium of the left endocardium of the septum, and includes the endocardium of the posterior wall. Whereas with the ASC standard, in the measurement of the cavity, the endocardium on the posterior wall is excluded because we measure here the leading edge, and the endocardium on the septum is included because we measure here with the leading edge, leading to leading edge. Of note, the formula that has remained in common use is the standard ASIN method, which is the leading to leading edge. And as you can see here on the right, the formula to calculate LV mass subtracts the cube of the LV cavity from the cube of the sum of the cavity plus the thickness of the walls. And then you have constants here. 1.04 is the specific weight of the myocardium. The result is then divided by the body surface area to have the left ventricular mass index. We always use the index of the mass in the report and to compare measurement between different patients. These down here are the upper limits of normal separated by sex. Now let's look at the limits of the M-mode technique used for left ventricular mass measurement. On the left, you see up here, you see a 2D image, left parasternal long axis view of the left ventricle with from top to bottom you have the right ventricular anterior wall, the right ventricular cavity, the interventricular septum, the left ventricular cavity, the posterior wall and the pericardium. But you will also see the aortic valve here, the aortic root, the ascending aorta, and the left atrium here. And the mitral valve leaflets, the anterior and posterior, and the mitral annulus here. Now the dotted line here is the M-mode scan line, the result of which down here is the M-mode tracing, which is the result of this scan. On the vertical axis of the M-mode tracing you have the scan depth, and on the horizontal axis you have scan time. So again you have the anterior wall of the right ventricle, the right ventricular cavity, the interventricular septum, the left ventricular cavity, the posterior wall, and the pericardium here, and these are the chordae, mitral valve chordae, because we are scanning just distal to the tips of the mitral valve to measure the LV cavity and wall thickness. And for the units, the distance between here, the vertical dots, is 1 centimeter, and the distance between two lines of dots is 1 second. And you can also see, because these are very old tracings, the phonocardiogram with the first and second heart sounds. Of course, the second heart sound is the aortic valve closure, so it's end systole. This is a normal patient with normal anatomy, normal geometry, and normal function. By the way, you can also recognize here the end systolic dip I was telling you about before. Here, here. And this is the posterior movement of the septum with the early right ventricular filling in early diastole. Now please note that the anteroposterior direction of the M-mode scan line is perpendicular to the long axis, to the direction of the long axis of the left ventricle, here from the middle of the mitral annulus up to the apex, such that the resulting M-mode scan is optimal. Optimal means that you are scanning perpendicular to the structure, and the endocardial lines here of the left ventricle, the posterior wall endocardium, the interventricular endocardium are linear structures, okay, with no uncertainties. In this situation, the measurement of the wall thickness and of the cavity is accurate and reproducible. On the right here, we have another example, and this time with a patient with hypertension, with a suboptimal M-mode tracing, which is secondary to the fact that there is an acute angle between the M-mode scan line and the long axis of the left ventricle. In this case, the calculation of LV mass will be greatly overestimated. Please note also in this hypertensive patient this localized mild hypertrophy of the proximal segment of the anterior interventricular septum, which is quite a common finding in these patients. This segment should not be included in the calculation of mass, otherwise it would greatly overestimate overall mass, because this small proximal hypertrophy does not influence, in fact, global LV mass, should not. So you can guess by looking at this image why in this case the M mode will give us an overestimation of mass, because you can see here that the M mode cuts with an oblique line through the septum, exaggerating its real thickness, an oblique line through the LV cavity, exaggerating the dimension of the cavity, and also the posterior wall. And you see down here in the M mode that you have this exaggerated systolic thickening of the septum, which is typical when you cross the septum with a diagonal line, and when the M mode scan is not perpendicular to the cavity. You can see here the difference between the M mode scan here in red in dashed lines and the dotted lines here, which is the measurement we do with M mode. And if you compare with the measurement done directly on the image on the 2D image, in this case you can measure perpendicular to the direction of the septum. You see the difference between the two measurements. The 2D is much more accurate. The same for the diameter. This is a diameter performed directly with a 2D measurement on the 2D image, and you can see that this is the real diameter and this will be the overestimated diameter by the M mode scan. And so this summarizes the reason why it is always preferable to perform 2D measurements for mass, and this is why M mode should not be used anymore. Now, the previous images were made with a very old echocardiographic equipment, 2D echocardiographic equipment. In contrast, I'm showing you another example with a present-day machine which is equipped with anatomical M mode, and the anatomical M mode technology allows the operator to move freely the M mode scan on the 2D image, thus overcoming the limitation of the non-perpendicularity of the scan relative to the orientation of the left ventricular long axis. So here you see the scan line should begin here from the transducer. Instead, it is moved, this green line is moved so that it can be perpendicular to the septum, LV cavity, and posterior wall. And this is what you would obtain if you didn't have anatomical M mode, with the M mode scan line originating from the transducer. So now you can compare in the same patient, the same moment, what happens if you can correct for the perpendicularity to the anatomy, and if you use a traditional M mode as in simulated here. So with traditional M mode, you compare to the anatomical M mode, the corrected view, you have an increased thickness here of the septum. It's 1.8 centimeter compared to 1.5 centimeter. And you see also here with a correct positioning perpendicular to the structure, you have a clear, thin, continuous endocardial line, and the endocardial line here is much less clear, especially during systolic thickening of the septum. It's interrupted here. It has you can also see clearly the overestimation of the cavity dimension compared to the correct positioning here. And here are another two possible pitfalls when measuring LV mass. On the left here, we have hypertrophy of the posterior wall, as you can see here, 1.36 centimeters, and whereas the septum has a normal thickness here, 1.1 centimeters, when measured distal to the localized hypertrophy here of the proximal segment of the anterior interventricular septum. The thickness of this focal segment here is 1.7 centimeters, so almost a severe hypertrophy. So if this were included in the measurement of mass, you would have a great overestimation of LV mass. This proximal hypertrophy also has does not influence the real or true global mass of the ventricle and has been demonstrated to have no prognostic significance at all. And it is quite commonly in hypertensive patients and in elderly patients even without hypertension. It should just not be considered. There are very few cases in which this septal hypertrophy has clinical significance, but they are quite rare. For example, in extensive akinesis of the mid to distal ventricle in acute myocardial infarction with a hyperfunction of the basal segments. In this case, this marked hypertrophy here could cause transient ventricular obstruction, but as I said, it's quite rare. On the right here, this right image, note that this is 2D performed with second harmonic imaging on a present-day machine. You can see the very high resolution of the anatomical structures of the left ventricle, and you see here again the measurement of the proximal segment of the interventricular septum, which is bigger than the measurement of the more distal segment where we should measure mass. So this here would overestimate LV mass, and this is the correct measurement. And this here with the asterisks are chordae inside the left ventricle, chordae which attach to the endocardium of the interventricular septum, and if they were confused with endocardium would greatly increase the measurement. So this is resolved by the high quality and high resolution of present-day machines. And of course, it's of great help to look at the clip in movement to decide if this is chordae or if this is endocardium. So again, today we must use for the measurements of the anatomical structures of the left ventricle to measure mass, or as I will see in a minute, LV thickness, relative thickness. We must use direct 2D measurements, 2D linear measurements on the 2D image, and we should abandon the measurements done with M-mode because of the pitfalls that we have just seen. And then we have the 3D method to measure LV mass, which is certainly the most precise, the most accurate. It doesn't require geometric assumptions, and it considers all the walls of the ventricle, as you can see. But it requires a dedicated transducer and software, which is expensive and is almost absent in out-of-hospital settings. It is necessary to have a very good 2D background resolution, so you must see very well the endocardium, but also you need to define well the epicardium, so to have the thickness of the muscle of the myocardium all around the cavity. You see here an example. You have a 4-chamber view, the orthogonal 3-chamber view. In here you have 3 short axes taken more or less proximally, midway between the annulus, mitral annulus, and the apex, and towards the apex. And these are provided so that you can correct the automatic placement of endocardium and epicardium provided by the software, as you can see here. Once that the operator has corrected the placement of the endocardium and epicardium and the tracings are judged as correct, then the machine provides you with end-diastolic and systolic volume and of course ejection fraction. And then you have the heart rate, the stroke volume from 3D, which should be quite accurate. And then you have the mass and the indexed mass divided by body surface area, in this case a normal mass. This is the end of video number 1. Please proceed now to video number 2, from relative wall thickness measurements to 3D LV volumes.